Now let me talk about chronic kidney disease. So as I said before, this is a slow, steady fall in creatinine clearance, and the blood tests will show a steady increase over time of the BUN and creatinine. It eventually progresses to dialysis for many patients, and the most common causes are diabetes and hypertension. Hypertensives get something called hypertensive nephrosclerosis, which makes the kidneys not work, and diabetics get diabetic nephropathy. Chronic kidney disease is split up into 5 stages based on the GFR. So if your GFR is greater than 90, but you have risk factors for kidney disease, we will call this stage 1. Stage 2 is when the GFR is 60 to 89. Stage 3 is 30 to 59. Stage 4 is 15 to 29. These patients are approaching dialysis. And then when the filtration rate falls to under 15, most of these patients are on dialysis, and they are stage 5. This is often called end-stage renal disease, or ESRD. You should know the indications for dialysis in a patient with renal failure. So if patients are significantly acidemic, that's an indication for dialysis. Electrolyte abnormalities, especially very high potassium levels, are an indication for dialysis. If a patient is intoxicated with certain dialyzable substances, we'll talk about these in a minute, then they should be dialyzed. We dialyze patients who have evidence of fluid overload, like heart failure. So if they have pulmonary edema because they're not excreting fluid, that's an indication for dialysis. And then finally, any of those uremic symptoms I talked about before mean that the patient needs dialysis. And most people remember all these indications by remembering A, E, I, O, U, which is the first letter of each of the indications. So this is a list of some of the dialyzable substances that patients will get dialysis for if they overdose on them or develop serious toxicity. So salicylates and aspirin are dialyzable, so is lithium, isopropyl alcohol, magnesium laxatives, and ethylene glycol. It's very rare to dialyze someone for these, but you can because the dialysis machine can remove these substances from the blood. So putting someone on dialysis means hooking them up to a machine that can filter their blood and do the job their kidneys are unable to do. And there are 3 main ways by which we do this. The first is called hemodialysis, and this is a picture of a man on hemodialysis over here on the right. You can see that there are large tubes connected to his arm, and those tubes are having blood drawn out of them. The blood's going through a filter in the dialysis machine and then being returned to the patient. So obviously hemodialysis requires significant vascular access to get the blood out of the body. The blood's pumped from the body through a filter and then goes back. And this is usually done in sessions a few hours at a time. So patients who are on dialysis will go to a dialysis center 3 or 4 days a week for 2 or 3 hours of dialysis, and this will do the job that their kidneys can't do. Another option is called peritoneal dialysis, and this is where you cycle fluid into the patient's abdomen and use the peritoneal lining as a filter. Essentially, the peritoneum is the dialysis membrane. This has to be done every night, so patients have to hook themselves up to a machine while they sleep, and this is basically only done for highly sophisticated, motivated patients who are willing to do this at home rather than come into a dialysis center. And then the final method of dialysis is called hemofiltration. This is very slow, constant filtering of the blood. This is usually done at the bedside for critically ill patients, and basically they're just hooked up to the dialysis machine for hours and days on end while they're critically ill. Vascular access is very important for patients on dialysis. So if someone goes into acute renal failure and needs dialysis, you can place a central line, but these central lines have a lot of problems. They develop infections and they develop blood clots and they don't last. The ideal method is to place something called a fistula. So this is a surgical procedure where a connection is placed between an artery and a vein, usually in the arm. These fistulas have the lowest rate of blood clotting and infection. They're very durable, and so for patients who are going to be on dialysis for the rest of their lives, this is the ideal way to go. The fistula has to mature, so ideally you place it several months before dialysis. If you're a nephrologist, you're always watching your patients, and when you think they get near dialysis, you recommend a fistula so that it will have time to mature before their kidneys completely fail. There are some complications of chronic kidney disease that you should know about, and the first one is anemia. So you lose erythropoietin when the kidneys don't work, and this can lead to a normocytic anemia. Many patients with chronic kidney disease develop dyslipidemia. Usually it's mostly high triglycerides. We think this happens because patients lose protein in the urine, and this stimulates liver synthesis. Patients with chronic kidney disease also have impaired clearance of some fats in the blood. Children with chronic kidney disease, it's rare for children to have this, but if they do, they can develop growth failure. And then the final complication is something called renal osteodystrophy. So to understand renal osteodystrophy, we have to talk about calcium and phosphate problems in renal failure. So when you have sick kidneys, the kidneys cannot excrete phosphate and the phosphate levels rise. The kidneys also can't activate vitamin D to its active form, so you get low levels of active vitamin D. The high phosphate pulls calcium out of the plasma and lowers the calcium level. and the lack of vitamin D causes decreased calcium absorption from the gut. These two effects combine to cause hypocalcemia, and then the hypocalcemia stimulates the parathyroid gland to make parathyroid hormone levels very high. What this means is that patients with chronic kidney disease can develop what we call secondary hyperparathyroidism. So the low calcium is constantly stimulating the parathyroid gland and raising levels of PTH. It's not primary because the problem is not in the gland itself, it's secondary to the renal failure. Now, if renal failure causes enough stimulation of the parathyroid gland, patients can develop what's called tertiary hyperparathyroidism. This is when the parathyroid gland has been so heavily stimulated by chronic kidney disease that the gland becomes autonomous. The PTH levels can get very, very high, and calcium can become severely elevated, and this often requires a parathyroidectomy because the parathyroid gland is no longer responding to calcium levels. It's gone off and operated on its own like a rogue gland. So now that we understand that, we can talk about the bone problems in patients with chronic kidney disease. So the untreated high parathyroid levels can lead to something called renal osteodystrophy. This is when the bones begin to degrade from chronically elevated parathyroid hormone. Patients complain of bone pain. This is the predominant symptom, and they're vulnerable to fractures because they have very weak bones from the high PTH levels. If it becomes severe enough, patients can get what's called osteitis fibrosa cystica. This is from untreated very high PTH levels for a long time. Patients get cysts in their bones, and they get these things called brown tumors, which are full of osteoclasts and fibrous tissue. And you can see them in this x-ray over here. There are these dark spots inside the bones, and those are brown tumors in a patient who's been exposed to very high PTH levels for a long time and has developed osteitis fibrosa cystica. Now, when nephrologists treat patients with chronic kidney disease, they try to avoid these bone problems by giving patients drugs called phosphate binders. These bind phosphate in the GI tract and bring the levels down. So these are things like calcium carbonate, calcium acetate, which goes by the name Foslo, and then sevelamer, which is Renagel, and another drug called lanthanum. So all of these are designed to combat that problem of very high phosphate levels in patients with kidney disease. Let me finish this module by just reminding you of some of the drugs that can affect renal function. So there are many drugs that worsen kidney function by decreasing the GFR, and these are all associated with rising BUN and creatinine levels in the plasma. So loop, thiazide, and potassium-sparing diuretics can all increase the BUN and creatinine because they interfere with the kidney's ability to concentrate and excrete urine. ACE inhibitors can vasodilate the efferent arteriole, and this can drop the GFR. And then NSAIDs can interfere with prostaglandin synthesis, and this can often drop the GFR. So be aware that patients on any of these meds may show evidence of increased BUN and creatinine and may develop acute renal failure. And that concludes our module on renal failure.